Hi, my name is Tara Crawford, and I will be discussing my evaluation project that took place at Maryhaven, and it will talk about the access to treatment in judicially referred substance use disorder clients. Maryhaven was founded in 1953 and has been voted the #1 nonprofit addiction treatment agency in Columbus since 2022. There are 4 campuses in the Columbus area and 3 satellite clinics in surrounding counties. Maryhaven provides residential outpatient and gambling treatment recovery and also has a specialized women's residential program. They have an engagement center for unhoused individuals, and they also have an addiction stabilization unit and central intake department. Clients served are typically Medicaid or uninsured individuals, and gap funding is provided by our local alcohol, drug, and mental health board. My role in central intake will be what my evaluation is based on. The central intake department takes referrals from walk-ins for outpatient treatment and gambling, and then also takes residential and detox referrals. A lot of the individuals that come in were probation or judicially referred, and that's what I'll be focusing on. A little bit of frustration came from the probation department concerning a gap in referrals and assessment to referral, and then no treatment taking place, which would lead to issues with extended probation or incarceration. So with an electronic health record change in mid-August, there was an opportunity to shift away from the old process and into a new scheduling process that was built into the new electronic health record system. So my question is, would an easier scheduling process reduce time between assessment and initial treatment sessions? So I found a journal article by Klaus et al. From 2002 that said participants who had a shorter wait time between assessment at central intake unit and their initial treatment appointment were more likely to show up. And so that's exactly what I wanted to look at in the old system versus the new. And some of the implications that prompted this were probationary communications and their frustrations. They kept referring to us, but they were very frustrated by the lack of communication and a little bit of ambiguity in the system. The fiscal responsibility at Maryhaven, these are opportunities to engage in treatment and make money. So that's a lost opportunity. Also, the community fiscal responsibility of incarcerating or engaging with high involvement with a probation program. And then ethically, our responsibility as social workers to our clients to, one, connect them with their best resources and to treat them with dignity. I found a systematic review by Brorson et al. From 2013 that discussed the treatment process factors influencing the number of sessions that clients attend and their completion rates. Agency change is difficult, especially with such a large agency and so many programs. So this opportunity really afforded us the ability to revamp that system and to hopefully improve outcomes for our clients. My logic model discusses a couple inputs that involve time with the quality improvement staff, both in the old system and in the new system. So I leveraged that with them to learn how to navigate and collect the data that I needed. And also it assumes my skills in data analysis that would enable this comparison of outcomes before and after the intervention. Some of the outputs were obtaining data for 4-month time span prior to the scheduling capability in these referred clients, and then also in the period 4 months after that time change, or that electronic health record change. And this would compare the engagement, that meaning time between referral and initial counseling sessions, the number of sessions participated in, and the time to complete treatment program of clients in the new and old processes. Some of the benefits or outcomes would be that clients receive motivational interviewing at the time of their assessment and at referral, and they're at a high state of change, and the consequences are very high for noncompliance. So clients do not experience ambiguity in the treatment plan and feel a little bit more trusting in the process. And also the criminal justice system and parole system have more trust in referring to this particular agency. Some of the medium outcomes would be reduction in prison and jail sentences and reduced probationary involvement. Clients are linked to care at the highest stage of their readiness after that motivational interviewing and the assessment process, and also reduced caseloads for parole and probation officers so they can focus a little bit more of their attention and resources on individuals who are in high need. Less taxpayer dollars are spent for incarceration or prolonged probation would be a long-term outcome. And then individuals will receive treatment are less impacted by substance use on their bodies, on their families, on their life outcomes. And individuals and their families are more likely to lead healthier and more productive lives. And then finally, this would prevent the traumatization that happens or can happen when one is incarcerated on individuals and their families. I had some assumptions here that the QI department would help me, that our counselors would be able to provide support and engage our clients, and that counselors would have time for all of the referred clients. And some of the external factors were that people just aren't ready for treatment. And that clients may not have the resources, that we kind of missed that in the assessment, that the barriers were really external. So what I measured were the number of days between their assessment and their initial treatment appointment, which is typically a treatment plan appointment with a counselor, the number of sessions that they attended, and finally, the nature of their discharge. Because of some factors, I limited the assessment dates to myself and one other central intake counselor who were consistent across all of those months of assessments. And then I also limited to 2 treatment counselors who served the level of care that we were referring to. We limited it to just level 1 outpatient and level 2 intensive outpatient care. And 2 counselors who provided those services. And we counted 18 weeks of data in the old system, 18 weeks in the new. And I collected all of those 18 weeks at 2 times in each of the 2 electronic health records. As far as reliability, it's a pretty standard measure of business days from time of referral to actual treatment. And then finally, the assessment and referral processes are pretty standard for our treatment settings. It kind of depends on how big the agency is, but it's pretty standard. My study lacks a little validity because some of the gaps in treatment are due to clients just not being ready for change rather than process failure. That's really hard to measure, but it just counts as non-engagement. Data collection approach was that I delved into the old electronic health record and the new, and gathered the data just at 2 different time points. So this was a program level quality improvement process evaluation. So I just looked at how we did things pre and post a change in the electronic health record, which allowed us to do that scheduling. So I just compared those 2 data sets of very similar referrals to the exact same 2 treatment counselors pre and post intervention. The rationale behind this was because of the probation expression of frustrations with us, the lack of clients getting treatment that were referred. We had a lot of people just getting discharged with no treatment. And then our ethical obligations to our clients to provide service in a timely manner and treating them with dignity. So keeping them from being incarcerated was also important. Things that were threats to our validity were staff changes, refinements in the process. So once we started doing the scheduling, I'll talk about it in a moment, but we did find that there were some things we had to shift. So that was a little bit inconsistent across those 18 weeks post-intervention. And then again, those clients just not being ready for treatment. So my first set of data are the pre-intervention days between assessment and first day of treatment. And so again, this is pre-intervention. I have 28 individuals, and you can see our mean line is there. It's at 16.7 days that it took for someone to get an appointment from assessment to first day of treatment. And you can see that number varies wildly. Some are, there are quite a few under. I wasn't sure how to notate this in this kind of chart, but all of them that are on the 0 line never responded or never connected with a counselor. So they never had an appointment. There was no contact. So those really low lines are terrible if they're at 0. Otherwise, typically it was about 16 days, almost 17 days. We do have a couple outliers that were upwards of 60 or 80 days. So then this is post-intervention. Again, we have about 28 individuals, and we have a mean line of 14.2. So we did bring that line down. A lot of the gaps between assessment and treatment are above 0. So we don't have anyone who was at 0 except number 39 here, and that person went to treatment on the same day, which is excellent. So that is an improvement. We do have a couple outliers that are above the mean, but overall it looks like visually looks like an improvement between the two. The next thing I did was compare the days between assessment and treatment, so that number of days on the chart, with the actual number of sessions that individuals attended. So here you can really see the gaps at number 8, 15, 18, and all of those with no bars, never engaged with Maryhaven after their assessment. Those individuals likely encountered difficulties with probation and may have been incarcerated. The blue bars, the taller they are, is a negative for me. And we do see some purple lines, which are positive because it means they did engage in treatment, but those numbers are pretty low and often are minimal. And so this would be post-intervention, the same measurement, and the red lines are the days between assessment and their initial treatment planning session. And then the purple would be the sessions that they did attend for treatment. And you can see that every bar every red bar has a purple bar, which is a very positive thing in my opinion. It means that everyone was engaged in treatment. We do have a couple lacking red bars or very low red bars, which is also great because that means they got into treatment very, very quickly. So some of my conclusions are that the mean time between assessment and initial treatment appointment fell from 16.7 days to 14.2. I think that's great. The mean difference is 2.5, which is practically significant. The standardized mean difference was 0.11, which is not statistically significant. So we're practically significant, but not statistically significant. But I think the more interesting thing is that we had clients showing up for appointments afterwards. So that purple line is something that I wish I'd paid a little bit more attention to. I didn't really anticipate that shift. So it feels like a good conclusion is that a little bit of clarity, even if it takes some time, but knowing the process and having some, some of that ambiguity cleared up really got people to stay engaged in the process. I mentioned some of the things that we encountered that we have to shift a little bit of stuff. Our counselor schedules filled up very quickly when we shifted this process, and we found ourselves scheduling people out 2 or 3 months even after the intervention. So they had to shift their process and have one treatment plan counselor who could look at the caseloads of all the various counselors and shift them to people who had room. So it feels like the counselors didn't have a full caseload because a lot of people weren't showing up or just didn't engage, whereas afterwards they filled up very quickly. So I also feel like that was a positive outcome. So I thank you. My references are the Borison systematic review and then the Klaus that discussed the engagement and the dropout rates of judicially involved individuals, and then also, of course, our social work ethics guide. So thank you very much for watching.